So my name is David McDermott. I'm a medical oncologist here in Boston at Beth Israel Deaconess Medical Center, where I'm the chief of medical oncology, and my practice focuses on melanoma and kidney cancer. So the lecture I gave at the ESMO Satellite Symposium was about the potential to turn kidney cancer into a curable neoplasm. With immune therapy in a growing number of solid tumors, we're starting to see patients achieve remissions of their disease. And we're certainly seeing that in some kidney cancer patients, particularly those who have deep responses to PD-1 based combination therapy, the ability to not just respond and improve survival, but to live off treatment or in treatment-free survival, live in remission. So what I tried to focus on was how do we create more of these remissions? How do we create more cures for patients with metastatic disease? And I focused on a couple of key things that we can do together as a field to improve outcomes. One is to improve how we select patients for immune therapies. Not all patients are going to benefit, so we shouldn't just broadly apply this treatment to all patients, particularly as the therapies get more toxic and more costly. We should also, try to focus on novel targets, in both the immune system and molecularly targeted therapies like the HIF-2 alpha transcription factor. And we should also consider in patients who have inadequate responses, who are not likely to have long-term survival, we should consider the model that's been laid out for us by our colleagues in lymphoma and testicular cancer, who, when they've not seen adequate responses, they've escalated the therapy to try to produce deeper remissions. And that may be possible in our patients with kidney cancer in the future through novel therapies like applying CAR T cells or tumor infiltrating lymphocytes, regimens that are just starting to enter our clinical trial portfolios. Well, while tumors that are PD-L1 positive tend to respond better to PD-1 based combinations in a variety of kidney cancer trials, there are plenty of patients who are PD-L1 positive who don't respond. And more importantly, there are PD-L1 negative tumors that do respond. So we can't use this staining as a way of selecting patients for our current treatments. In general, kidney toxicity in patients with kidney cancer on PD-1 is uncommon, probably 1% or less in the trials that have been reported. What I tried to emphasize, though, in our kidney cancer patient example that I showed was that sometimes PD-1 toxicity can happen late. In the example that I showed, the patient developed acute renal failure in the setting of a urinary tract infection after 4+ years on PD-1 based therapy. So my point was not that nephritis is a common side effect, it's just that late side effects can happen and we need to look for them in our patients. So in a number of kidney cancer trials over the last several years, we have seen certain subsets of RNA signatures being associated with outcome to not just immune checkpoint blockade, but also angiogenesis blockade. Probably the best example of these associations has been in the Emotion 150 and the Emotion 151 studies. Some of this data was recently published late last year in Cancer Cell by Dr. Motzer and Arini in a paper that looked at distinct subsets that had an increased chance of benefit to both either sunitinib or to atezolizumab-based therapy. It was the T effector and the proliferative subsets of genes. When they were overexpressed, patients were more likely to respond to the immunotherapy-based approaches. And whereas, not surprisingly, when tumors were expressing high levels of angiogenic gene signatures like a high VEGF signal, they were more likely to benefit from angiogenesis blockade. So this work gives us a sense that RNA analysis may help us refine our approaches going forward and may also identify a patient population that is unable to respond to either approach. We obviously need to refine this in future trials with better tissue collection and analysis Going forward, this approach is not that easy given the heterogeneity that's associated with kidney tumors, particularly when they're metastatic, but it must be pursued, so we can sort of rationally apply therapy to the right patients. Well, I think the biggest change that's coming is likely bringing immune therapy, immune checkpoint blockade earlier in the treatment strategy. So we saw data this year at ASCO with pembrolizumab in the adjuvant setting for stage 3 patients, which was encouraging improvements in disease-free survival and an early hint of potential impact on overall survival, but that data is early and reasonable tolerability. So by bringing immune therapy earlier, we may see better outcomes. There's another important trial called the PROSPER trial, where the immune therapy is started actually before surgery that should produce some interesting results. We've seen that pre-surgical PD-1 is active in other tumor types like bladder cancer, melanoma, and lung cancer. So potentially it could be active here in kidney cancer. I think that's the biggest innovation coming, but we're also going to see complex regimens like triplets, for example, of combining VEGF, PD-1, and CTLA-4, for example, in the COSMIC trial. There'll be a number of other triplets coming, and hopefully the benefits of those triplets will outweigh the costs and the toxicities that will likely be associated with them, but we obviously need to ensure that before we pursue them going forward.